Welcome to Omnicurus Originals. We are celebrating the Diabetes Awareness Month, and today we have Dr. Deepak Rastogi with us. Dr. Deepak Rastogi is a present secretary of RSSDI Uttarakhand chapter. He is one of the most senior diabetologists in Uttarakhand, and he is also the managing director of Jeevan Deep Hospital in Uttarakhand. We are very pleased to have him today with us. Welcome, Dr. Deepak Rastogi. The stage is all yours. You may please begin.
It's very nice, and I'm happy that I'm addressing all of you people. It's going to be a good interaction, I hope. Today, we'll be talking about macrovascular complications of diabetes, which are mainly coronary artery disease, stroke, and peripheral arterial disease. It's very important in the context of diabetes, the way the diabetes is increasing in our country, a very, very high number, and the WHO predictions are there, IDA predictions are there, that in 2030 it is going to go further and further. So, if we do not prevent or do not diagnose in time all these coronary artery disease, stroke and peripheral artery disease complications in our diabetics, it is not only going to be a health burden, but also going to be an economic burden. No country in the world, whether it is rich or poor or developing or developed, even developed countries, cannot cope up with the number of diabetics they have if they start having complications. And each complication costs in the if you consider man days, lost, if you consider money lost, if you consider a burden to the exchequer, or if you consider a burden to the health system. So let's be aware of the macrovascular complications. Let's be aware of their importance. And so first of all, we should think of the origin. See, diabetes is a very much a metabolic and an inflammatory disease. A lot of these autoimmunity factors are involved in diabetes. So we must know that it arises, all the cardiovascular, atherosclerosis, hypertension arises from the common soil. So this common soil we must always keep in mind. There is glucotoxicity, lipotoxicity, inflammation is there, and this causes insulin resistance and endothelial dysfunction. And they sort of support each other. Insulin resistance causes diabetes, obesity, dyslipidemia, and endothelial dysfunction causes coronary artery disease, hypertension, and atherosclerosis. So if you understand these mechanisms which are causing the common soil phenomena, then you will be more careful in treating your diabetics so that you diagnose them early and you can then treat them early. What is the continuum of cardiorenal metabolic risk? This is interrelated disease of type 2 diabetes mellitus, CVD, heart failure, and chronic kidney disease. Risk factor like diabetes, hypertension, if you see on the left side, lower portion of this cartoon, diabetes, hypertension, obesity, and dyslipidemia, which leads to endothelial dysfunction, which leads to microalbuminuria, then coronary artery disease, then macroalbuminuria. Now, you have to be careful. Even microalbuminuria is an indicator that your patient is going to develop some cardiovascular disorder or maybe some cerebrovascular disorder. Macroalbuminuria, then comes MI and stroke, then chronic kidney disease, then LV remodeling, heart failure, end-stage renal disease, and then cardiovascular death. What I'm trying to stress today is that he's not heading into cardiovascular death immediately. He's going through all this cycle, and all through this he's suffering from many complications. It's a great burden to the nation, it's a great burden on himself, it's a great burden to the family economically also, and his health wise and his work wise also. So we have to be careful. Now, what are the risk factors for developing multi-vessel disease? Hyperglycemia, diabetes is there, hyperinsulinemia is there, metabolic syndrome is there, insulin resistance is there, obesity is there, hyperlipidemia, hypertension, physical inactivity. So, and if you remember, cardiovascular disease or cerebrovascular disease also share the same risk factors. So, common soil is there, Both the diseases are sharing the same risk factors and they are helping each other to grow in the body. So if you have to, the aim of each diabetologist is not only to control glucose but to control these complications also. I'll be discussing this CVD, which is cardiovascular disease in diabetes mellitus, in 3 headings: coronary artery disease, cerebrovascular disease, which is stroke, and peripheral artery disease. In our country, coronary artery disease is the most common, so I'll be spending some more time and I'll be explaining what kind of coronary artery diseases can be there, what kind of cardiac diseases can be there. Not only coronary but non-coronary cardiac diseases also can be there in a diabetic, and you have to be on the lookout. In the whole talk, I'm going to stress on the point that as a diabetologist, as a general physician, you must be on the lookout for complications. If you miss the bus, the patient will land up with some complication, and then you will have nobody to blame except yourself. So let us start with coronary artery disease. Atherosclerotic coronary cerebrovascular disease or a cardiovascular disease normally involves coronary circulation, which is mainly proximal LAD, cerebral circulation at the bifurcation of carotid artery, and abdominal aorta at the origin of renal artery. So it has enveloped, the whole body. Stroke is there, renal stenosis is there, cardiac things are there. 2 out of every 5 asymptomatic patients of 2 diabetes mellitus may have significant coronary artery disease. Patient may not have any symptom and he may have a significant coronary artery disease. Now it is the duty of the physician to dig it out and to tell him and to warn him. And whenever he is coming to you, you must warn him that 2 out of 5 patients who are asymptomatic may have significant coronary artery disease. So you have to be careful regarding that. Let's talk about coronary artery disease. I'll give you some facts, and these facts you must remember, because if you remember those facts when any diabetic walks into your chamber, you remember those facts, you will look at him from that perspective. Diabetics have 2 to 4-fold increase in incidence of coronary artery disease. Prevalence, not only coronary artery disease, but the prevalence of CV complications is also 5-fold high. He will not only develop coronary artery disease, but he is 5 times more chance of developing complications. So diabetes is considered now as a CAD risk equivalent. If a person has a CAD and no diabetes is equal to no CAD and diabetes. Both fasting as well as postprandial hyperglycemia are associated with increased CADs. So it is not only for you to control fasting, as you have to control postprandial also. You must think of time in range concept. If your patient is 70% time in range, it means you are successful if you are treating the hyperglycemia. The aim should be that 70% time of the patient should be in time in range. Now in diabetics, it occurs 20 to 30 years before as compared to non-diabetics. So diabetics are having this coronary artery disease at a much younger age. So their output decreases, their productivity decreases. So it is causing again an economic burden to the nation. Their own family suffers. Women with diabetes are more prone to develop coronary artery disease, and they lose this female hormone protection when they develop diabetes. If a non-diabetic lady is there, she has much less chance of developing coronary artery disease than a diabetic woman. In fact, women are more prone to have coronary artery disease and complications of coronary artery disease than men. So don't think that a woman is menstruating, she has the natural estrogen and progesterone safety. If she is diabetic, must think of coronary artery disease, What is the nature of coronary artery disease in diabetes? It's more severe, it's more complex. Complex means multi-vessel disease. If a diabetic is there, must think of 2-3 vessel disease. Hardly ever you see a diabetic who is suffering from single vessel disease. And they have poor prognosis. Even if you do a bypass surgery, their prognosis is worse. Their plaques are longer, they are more in number and are soft with high rate of ulceration and thrombosis. So even if they are going for angioplasty or they are going for bypass surgery, their plaques are creating a lot of problem for the interventional cardiologist. So you have to be careful not to let him develop this. You will only be able to do it if you diagnose it early. We'll come to that. I'll just tell you some more facts. Risk of heart failure is 2 to 4-fold in men and 5-fold in women with diabetes. He doesn't only have coronary artery disease, he can suffer from heart failure also. He or she. His heart failure chances are much more. And cardiovascular mortality is higher in Asian Indians as compared to their counterparts abroad. Diabetics die 5 to 10 years earlier than non-diabetics. Metabolic syndrome is also a risk factor. Now, why I have put this in bold is that just 1% decrease in HbA1c can cause a 14 to 16% decrease in CV events. So now, two things. Number one, you have to control the HbA1c, you have to control the hyperglycemia, and not only hyperglycemia of fasting, but even post-pandemic. Then you have to be on the lookout for any coronary artery disease, because 2 out of 5 patients of yours who are diabetic will have an asymptomatic, full-blown, significant coronary artery disease. Don't wait for symptoms. You have to diagnose them earlier. Hypertension also plays a very important role. It's surprising. Prevalence rate of hypertension in type 1 diabetes mellitus is 30% and type 2 is 60%. So 60% of your type 2 diabetic patients will have hypertension. So there is a progressive continuous relationship between systolic and diastolic blood pressure and risk of CV death and MI in diabetes mellitus. If you control the hypertension of your patient, he is much less likely to develop coronary artery disease and cerebrovascular disease and kidney disease. Cerebrovascular disease, hypertension is one of the major factors. Diabetic dyslipidemia is very typical. The person will have high triglyceride, low HDL and high LDL. So you have to think of dyslipidemia also. Again, everything is interrelated with each other, interlinked with each other. Dyslipidemia, obesity, hypertension is interrelated. Atherosclerotic CVD, all these things are correlated. Diabetics, what are the clinical features now? Let us discuss how. I have been stressing on how to diagnose cardiovascular disease or cerebrovascular disease or coronary artery disease in diabetics. So, and I also said that 2 out of 5 patients are asymptomatic. Chest pain may be present or may not be present. They may just present with simple arrhythmia. He will just come and he is having arrhythmia. He has no chest pain, no history of heart attack, no history of any coronary artery event. He may just present with heart failure. He will just come to you with a breathlessness. And he may have coronary artery disease. So shortness of breath is a major and frequent symptom and is considered equivalent to angina. Because diabetics may have apparently asymptomatic CV damage, they may not suffer from chest pain. So either the chest pain may be present, or it may be absent, or it may be atypical. He may have a pain in the tooth, he may have pain in the lower abdomen, lower mandible, or he may have pain in the right side of the chest, or he may have pain in the epigastric region, or he may present with heart failure and arrhythmia. And you must not ignore any kind of breathlessness of any degree in a diabetic. Patients have tendency to give various funny reasons that I have walked fast into a chamber, or I just came hurriedly, that's why I am having this and that. You have to take it seriously. If your patient of diabetes is having any dyspnea of any grade, take it seriously. He may have some coronary artery disease which you have to find out. You have to dig out. A diabetic should always be doing the role of a Mali, the gardener. He has to dig out. And how do you diagnose? There can be a painless ST segment depression in ECG. And echo is the most important screening test. Every diabetic should undergo echo, even if he is symptomatic or not. Make it a routine in your practice of diabetics to do a echo. You may see a regional wall motion abnormality while the patient has never had any complaint. And diastolic dysfunction in diabetics is considered to be the most important thing, because these are the patients you have to separate will be going one day or the other into systolic failure. Then comes stress echo. Stress echo is a very good and very helpful test for diabetics to diagnose coronary artery disease. It provides greater diagnostic accuracy than TMT. Albuminuria, and as I told you earlier, albuminuria is a very important marker. Any patient who has albuminuria, you must think of coronary artery disease. Treadmill, exercise-induced ST depression of more than 1 mm in the absence of coronary artery disease symptoms are considered as silent MI. We'll talk about silent MI. CT angio is a very good test for diabetics. They must undergo CT angio if you have any suspicion. What is silent myocardial ischemia? Silent myocardial ischemia can occur in diabetics who are of more than 5 years of duration, who have hypertension, whose smoking history is there, dyslipidemia is there, family history of coronary artery disease is there, and target organ damage is there. Target organ damage means peripheral artery disease, high coronary artery calcium score, low ABI, and increased carotid intermediate media thickness. So, if you have a diabetic who is obese, who is physically inactive, he has family history of coronary artery disease, he has dyslipidemia, he smokes, hypertension is there. You should think on these lines that he is the more likely candidate of developing coronary artery disease. If he has target organ damage like peripheral artery disease, he has this claudication, or he gets tired very soon. And on carotid Doppler, if he has a carotid intima media thickness, even if the plaques you are seeing on the carotid bifurcation or any other area in the carotids are not very, don't look very fragile, but still the plaques are there, and he has dyslipidemia. So there are chances of going into, and he has more chances of, because you see the atherosclerotic plaques are not selective. They are not going to a single artery. They are affecting the whole body, the whole arterial tree. And what are the markers of silent CVD? I always insist to my colleagues that we must not shy away from asking our diabetic males about erectile dysfunction. I think that erectile dysfunction should be treated as a CAD equivalent, because if the erectile dysfunction is there, he may be having a silent CVD. Micro and macroproteinuria, renal artery narrowing, increased carotid intima media thickness, and high sensitivity CRP, high sensitivity TROP-T. If they are level increased, there are more chances of developing. But erectile dysfunction is very easy. You can just ask. Why shy? Why shy away from these things? Patients normally do not discuss. They don't want to discuss about erectile dysfunction. But you can ask them. You can send the nurse who's standing in the chamber out, or maybe the patient is more comfortable in the second or third visit. When he's more familiar with you, you must ask him if he's having any erectile dysfunction. You must check his albumin, urine for albumin. If he's having any microalbuminuria or macroalbuminuria, you must think about that. And if he has hypertension, you must get a renal artery color Doppler done to see whether stenosis is there or not. Then, interestingly enough, diabetics not only have coronary cardiac complications, but they have non-coronary cardiac complications. I've seen a lot of patients, diabetes, just having diabetic cardiomyopathy. He has nothing but dry cough, dyspnea on exertion, and paroxysmal nocturnal dyspnea. Now, sometimes the things get confused. If he's a smoker, he says he's been smoking a lot, he's got cold, he's got a cold. Fine, everything is fine. It is our duty to diagnose, to fish out whether his cough and dyspnea on exertion and paroxysmal nocturnal dyspnea is because of diabetic cardiomyopathy or any other reason. ECG may show right bundle branch block and signs of LVH without hypertension. And echo is again the most important test. So many times we see LV diastolic dysfunction, asymmetrical septal hypertrophy, concentric LVH. We see so many times concentric LVH. And I ask the patient when I am doing the echo, do you have hypertension? He said, I have never had any hypertension. And he is diabetic. He doesn't have hypertension. His BP is 130, 90, 120, 80, and he has concentric LVH. He says, I have never had any hypertension. Then systolic dysfunction may be there. LV dilatation may be there. Reduced ejection fraction may be there. In diabetics, even HFpEF with diastolic dysfunction is considered significant. Global hypokinesia may be there. Functional MR and TR, mitral regurgitation, tricuspid regurgitation may be there because of dilatation of the LV. So the patient may be asymptomatic, patient may be having some amount of dyspnea. He must undergo, every diabetic who has breathlessness or dyspnea or paroxysmal occult dyspnea or dry cough should undergo echo, and you will be surprised to know when echo you may find so many things. And non-coronary diabetic cardiomyopathy is not that uncommon. Then another thing which cardiac complications these diabetics have is CAN, cardiovascular autonomic neuropathy. Cardiovascular autonomic neuropathy is very common. 22% of patients of type 2 diabetes mellitus and 17% of type 1 diabetes mellitus suffer from CAN, that is cardiovascular autonomic neuropathy. It's a definitive and independent predictor of mortality in diabetes mellitus. 25 to 50% of patients exhibiting symptomatic CAN can die within 5 to 10 years. Now, if you missed CAN in your diabetic, you missed cardiovascular autonomic neuropathy in your diabetes, he may just be dead one day. Because they may present with sudden cardiac death, they may present with cardiac arrhythmia, he may just have a ventricular tachycardia and he may die. And it is associated with increased prevalence of LV diastolic dysfunction. So if you find the LV diastolic dysfunction in a person who has got less, you have to correlate. You have to correlate that, okay, he may be having only LV diastolic dysfunction is there, ejection fraction is normal, LV size is normal, his LV parameters are normal, LVH is not there. So you have to think about, he may be having coronary cardiovascular autonomic neuropathy. That is the cause of diastolic dysfunction. Then you go ahead and investigate. How do you do that? These are the screening signs of or cardiovascular autonomic neuropathy. So if the patient is having resting tachycardia, the patient doesn't have, if your diabetics doesn't have anemia, doesn't have thyrotoxicosis, doesn't have any other cause, a fever or any other cause of tachycardia, and he has resting tachycardia, you must think of that. Orthostatic hypotension, reverse dipping of BP profile, and QT interval prolongation. You must see when you do an ECG, you must see the QT interval, and if any of these things are found, you must think of cardiovascular autonomic neuropathy. A change of less than 10 beats per minute on deep breathing, no change in heart rate on standing, less than 10 mm fall of BP on standing. These three things can be achieved, can be seen, can be examined by your assistant also if you don't have time. Make it a routine in your clinic that any diabetic who comes, tell them to take his BP lying down, take his BP standing, and then see the difference. Then you see if there's any heart rate, tell the nurse to take the pulse when the patient is lying down and then standing, and then you see, let the patient debrief and take the pulse again, and these figures should come in your paper in front of you when your assistant or your nurse brings the patient to you. Then it will save your time also, and you will have an idea. Okay, this patient of mine has to be treated separately. He may be having CAN. Then, so we discuss about coronary artery disease. Heart disease can be coronary artery disease, which is the major chunk of macrovascular complications of diabetes. Your patient can have a diabetic cardiomyopathy, and your patient can have a CAN, which is cardiovascular autonomic neuropathy. That's right. So he can present in any of these things, and you have to be on the lookout. Be on the lookout. Treat dyspnea. I have seen so many physicians ignoring dyspnea in the patients, ignoring cough in the patient, just giving him cough syrup. You have to think of cardiac causes first. And if you rule out, I am not saying that every diabetic will, if he has cough, he will be having some low ejection fraction or something. But you cannot say that he doesn't have low ejection fraction unless you diagnose, unless you investigate. So don't hesitate to investigate all your diabetics, because 2 out of 5 patients of diabetes may be asymptomatic. And you have to fish out, you have to dig out your patients who are having coronary artery disease. I will give full marks to a physician whose diabetic doesn't suffer an MI, and if he has triple vessel disease or double vessel disease, he goes in for the preventive either angioplasty or if required. If he suffers a heart attack and then you diagnose, I won't give good marks to that physician. Okay, let's talk about peripheral arterial disease. Peripheral arterial disease is a condition characterized by atherosclerotic plaque of different grades, procuring stenosis and occlusion in the arteries of lower extremities. The atherosclerotic changes seen in coronary and carotid arteries are also seen in peripheral arteries of lower limbs, especially if your diabetic is a smoker. Then you have to think twice about peripheral arterial disease. So how do you suspect or how do you diagnose peripheral arterial disease in a diabetic? More than 50% of patients are asymptomatic or have some leg pain. 1/3 of patients have present with claudication and 20% of patients of diabetes with occlusion negative peripheral arterial disease develop gangrene of toe. So if you're patient, you must ask, how much are you walking? Because of course, we always tell our patient for lifestyle modification and we tell them to exercise. Sometimes patient, you say, ask him or her, okay, now when you go for a walk, do you have any leg pain? If he says yes, okay, when you sit because of the leg pain, does it go off? So then your mind should start thinking, he may be having some clot somewhere. I must get his lower angiography done, or I must get some tests done, ABI, I must check his ABI. So you know that this patient is going to develop or already has developed. And it is always good to remove that plaque before he develops gangrene or any other infection. Mind you that ABI is an independent predictor of increased risk of CV events and mortality in asymptomatic patients. So microalbuminuria is an independent predictor, macroalbuminuria and ABI. Please start checking ABI in your clinic. How do you measure? We all know there's no need to go into details of all this. And interpretation, less than 0.5 ABI severe PAD, 0.5 to 0.8 moderate PAD, 0.8 to 0.9 some PAD may be there, 0.9 to 1 is acceptable, 1 to 1.4 is normal, and less than 1.4 again means calcification or vessel hardening. So if a patient does more than 0.8, less than 0.8 or more than 1.4, you must take action. Then we come to stroke. A lot of these diabetics have stroke, and they just develop blood just like this out of the blue. They develop stroke. You are wondering, he was okay till yesterday. Why did he develop this infarct? Why did he develop hemorrhage? That is because I failed to see him. I failed to do his carotid Doppler. I didn't see the carotid media thickness. I didn't see the plaques. I didn't see his level of hydration. I didn't control his hyperglycemia. I didn't control his dyslipidemia. Let's see what I could have done for this patient. Annual incidence rate of stroke is 123 per 1 lakh population. Men 99.5. Surprisingly, in women 149.5. Women are more prone to develop stroke. Diabetic women are more prone to develop stroke as compared to men. 95% develop stroke. It's horrible for the family, horrible for the person. So let us prevent. Let us think of prevention of complications. Today we are going to stress on that is why in my talk I have not added any management. I'm just going to tell you the magnitude of the problem. I'm telling you the magnitude of the problem. I'm telling you the early diagnosis of the problem so that we can prevent. Because in prevention only our bhalai is there. Where we cannot do any bhalai of any within the public or diabetics without prevention. Ischemic stroke is more common in diabetics than hemorrhage. Women with diabetes are more risk of developing cerebrovascular disease, and not only developing cerebrovascular disease, but the prognosis is also worse. Stroke outcome and morbidity was worse in diabetics. So as compared to non-diabetic, recovery rate is much less in diabetics. Both short-term and long-term recovery is dependent on blood sugar levels. So blood sugar level is important. I am not denying the fact. But you have to think and diagnose, try to diagnose. In diabetics, lacunar infarcts are more common. Cerebral small vessel disease is more common than large artery disease. TIA is always there. So if a patient comes with a history of TIA, you must start diagnosing, you must start thinking. threefold increase of TIA, and he may go into a full-blown stroke without any warning. Just suddenly you try to wake up the old man or old lady, she will not get up. And you will say, Mataji, raat ko to theek thak soi thi, ab subah kya ho gaya? But she slept well, right? What happened in the morning? So she may just go into full-blown stroke without any warning. Diabetes is an established risk factor, not only for stroke, but cognitive impairment also, dementia also, and Alzheimer also. So by controlling your hyperglycemia, by controlling your dyslipidemia, by promoting exercise and lifestyle modifications, by reducing obesity, you are dealing with so many problems. Your patient is free of so many problems like stroke, cognitive disorders, dementia, Alzheimer, and all these things. Coronary artery disease, peripheral artery disease. What are the CV risk stratification in diabetics? Age. Transition from low to high risk at an age of 45 is men, 56 years in women. They go into multiples after this age. So that's why I'm saying you have to catch them young, and we are getting diabetics, very young diabetics, and we have to catch them. We don't have to, they should not be crossing that age when suddenly the CV risk increases. Hypertension, as I told you, reduction of 10 millimeters of mercury lowered the risk of mortality by 13%, CVD by 12%, and stroke by 27%. No diabetic of yours should go without controlling his or her hypertension rigorously. You must control the hypertension. They may not care because they may not care for blood sugar, they may not care for hypertension, because these things do not pain. And if he has an injury in leg, he'll be howling. But if he has a high blood sugar, he won't. ठीक है, सब चलता है. 200 तो नॉर्मली रहती है मेरी, 150-90 तो नॉर्मली रहता है. This is not normal. You have to tell him, Mister, you are at 27% more chance of developing stroke. You better be careful. Hypercholesterolemia, you have to control the LDL. Now we say that less than 70 LDL should be the aim on diabetics. Smoking is 48% total risk of CV mortality, very high risk. Family history, if one relative is there, 50% risk is there. Two relatives there, 75% increased risk is there. BMI, as I said, obesity. And nowadays, non-alcoholic or alcoholic fatty liver disease also. Get a fibro scan done. If his beta score is high, more than 12, you have to warn him. That you have to take care of your liver, because all this extra fat is deposited in your liver. Then, with obesity, sleep apnea is there. You control the sleep apnea on your patient, and hemoglobin HbA1c comes down, the blood pressure comes down. It's very magic. It's like a magic. And with this, with the scenery of hills in my state of Uttarakhand, I end my talk, and thank you very much.